Welcome to PGOG, Obstetrics and Gynecology for postgraduates and consultants. And today's topic is anemia complicating pregnancy, question answer format. For this topic, I have selected this question answer format. The main reason is anemia complicating pregnancy is the commonest long case kept in the practical examination. So first question is, how do you define anemia in pregnancy? The CDC definition is hemoglobin which is less than 5th percentile, and it comes to normal hemoglobin, the cutoff is 12 gram per dl in a female, whereas in pregnancy, first trimester and third trimester, cutoff is 11 gram per dl. That means anemia is present if hemoglobin falls and it is less than 11 gram per dl. Second trimester, it is less than 10.5 gram per dl, and postpartum, it is less than 10 gram per DA. Now, for students, one advice or one tip for the practical examination is you yourself start explaining the reasons for this rather than letting examiner ask you a sub question that why the level is lower in second trimester and it is even lower in the postpartum period. You yourself start answering. Take every question as an opportunity for you to showcase your knowledge. That way you don't stop talking about the topic unless you feel that the answer is complete and there is no possibility of any sub questions. So why it is lower in second trimester is hemodilution is maximum in second trimester. What is happening in third trimester is RBC mass keeps on increasing but plasma volume remains same, and that is the reason the cutoff has gone back to 11 gram per dl in third trimester. Postpartum, there is a fluid shift, which is a major fluid shift, which is occurring from extravascular compartment to the intravascular compartment, leading to further hemodilution, and that is why the cutoff is lowest in postpartum period. It is less than 10 gram per dl. Now, what are the common causes of anemia in pregnancy? All over the world, iron deficiency anemia is number one. Whereas number two cause of anemia in pregnancy is acute blood loss because obstetric hemorrhages are very common. Dimorphic anemia is quite common, especially in the low or middle income countries because nutritional deficiencies lead to deficiency of folic acid as well as iron. Megaloblastic anemia, where there is a major reason is folic acid deficiency during pregnancy, and thalassemia minor and sickle cell disease or sickle cell trait are also commonly observed in belts or areas where these diseases are common in some communities or in certain areas. How do you diagnose iron deficiency anemia? The first step or most informative investigation is a complete blood count, or even if you are asked which is the investigation of choice in a case of suspected case of anemia, your answer should be CBC. Peripheral smear for typing of anemia should also be done. Iron studies are done in selected cases, and bone marrow biopsies or bone marrow analysis is acquired in rare cases, but it is gold standard. In low resource settings, trial of iron therapy is used to diagnose iron deficiency anemia instead of doing iron studies. Now, what is the difference between CBC and peripheral smear? CBC is done with the help of CBC analyzer, which gives results. It can be run by even a technician. It gives parameters such as MCV, MCH, MCHC, etc. Peripheral smear, pathologist reads the slide. Characters of cells are identified. Typing of anemia can be done by peripheral smear but not by CBC usually. Microcytic hypochromic RBCs, macrocytic cells, target cells, pencil cells, such type of abnormal cells are identified whenever a peripheral smear is examined. So for us, it is important to remember that only CBC is not sufficient. CBC with peripheral smear is more informative for to know the type of anemia, to know the exact or come to a probable diagnosis of cause of anemia. What are the features of iron deficiency anemia on CBC? CBC is a simple, inexpensive, rapid test, and it helps in early diagnosis of iron deficiency anemia. CBC includes hemoglobin, MCV, MCH, MCHC. All these are lowered in iron deficiency anemia. MCV is lowered and there are microcytic RBCs are present. Now, mean corpuscular volume is, it gives you the mean or of this volume of the red blood cell or RBCs. It gives us a mean of the volume. But what is happening is, if peripheral smear is done, microcytic RBCs are observed in peripheral smear, and it is considered as one of the earliest feature of iron deficiency. But remember that in 40% of iron deficiency anemia, we can have normocytic RBCs. But it is the first to show a change in iron deficiency anemia, MCV, low fall in MCV. Now, next is important in CBC is red cell distribution width or RDW. RDW is where we see the how much is the change in the it is a measure of change in RBC width, and it is same as we say anisocytosis. Anisocytosis is change in the size of RBCs. Various sizes of if the RBC size differs dramatically when the peripheral smear is being examined, it is called as presence of anisocytosis. Same is identified by a CBC analyzer with this RDW. Now RDW, this is how this is red cell distribution width, normal. But what is happening with iron deficiency is this red cell distribution width increases. That means the range of the RBC volume is more with the iron deficiency anemia. That is why there is increase in red cell distribution width. Fall in MCV and rising red cell distribution RDW is typical, most typical feature of iron deficiency anemia on CBC. Now, when patient is given treatment, there is sudden increase in RDW, and it also RDW helps us to indicate that patient is responding to treatment. What is dimorphic anemia? It is anemia because of both iron deficiency and folic acid deficiency. Initially, we can see features of iron deficiency, and when we start iron supplementation leads to unmasking of folic acid deficiency. Peripheral smear will show presence of both micro and macrocytes, but mean corpuscular volume will be normal because it is considering only the mean. So it won't be able to tell us that it is a dimorphic anemia. That is the drawback of only banking on CBC. And it is this dimorphic anemia is the most common type of nutritional deficiency anemia. Now, what are the stages of iron deficiency anemia? We say typing, we say grades, and we say stages. So what are the stages? Stage 1 is when there is only depletion of iron stores, whereas erythropoiesis and hemoglobin is normal. Stage 2 is further depletion of iron stores along with abnormal erythropoiesis, where there will be presence of microcytic hypochromic RBCs, but hemoglobin is still normal. Stage 3 or the last stage is when there is a fall in hemoglobin. So whenever we get a patient who has a fall in hemoglobin and then we diagnose it as iron deficiency anemia, remember it is the last stage of iron deficiency. It is stage 3 where the stores are almost completely depleted, abnormal erythropoiesis is already there, and then the third is the fall in hemoglobin. So always whenever we see a patient of iron deficiency anemia with a hemoglobin which is lower than the cutoff, remember that stores are already depleted, abnormal erythropoiesis has already started, and it is stage 3 of iron deficiency anemia. So this is pictorially we can see here. This is iron store, and as stage 1 there is only the depletion of iron stores, whereas the RBCs remain same and the hemoglobin is normal. Stage 2 further depletion, but the RBCs are becoming microcytic hypochromic, but hemoglobin is still normal. Stage 3 is where all these three features are there. Depletion, profound depletion of iron stores, CBC changes, hypochromic microcytic RBCs, smaller RBCs and more paler RBCs are seen, and there will be a fall in hemoglobin. Whereas grade is by WHO as per the hemoglobin, gram per DL. 10 to 10.9 is 9 in pregnancy, especially first and third trimester is grade 1. 7 to 9.9 is grade 2, less than 7 is grade 3. ICMR has added fourth grade as less than 4 gram per DL. What are the iron studies which are done in a case of anemia? Your answer will be ferritin, serum ferritin, serum iron, total iron binding capacity, transferrin saturation, soluble transferrin receptor level, and free erythrocyte protoporphyrins. These are the newer ones which have greater sensitivity and specificity also to detect iron deficiency anemia. So commonly used are serum ferritin and TIBC, and in case of doubt, this soluble transferrin receptor is used commonly nowadays. What are the indications for iron studies? Do we do iron studies in all suspected cases of iron deficiency anemia is a common question. Usually in a low resource setting, it is limited. There are limited indications and it is not necessary to do the iron studies before starting oral iron therapy in low resource settings. Whereas in good resource settings, we can go for iron studies as a primary investigation before initiating the treatment. So in low resource setting, main indications will be non-responders to iron therapy. Then before iron therapy in thalassemia minor or sickle cell trait, because these here in these cases also nutritional iron deficiency is very common. And before starting parental iron therapy, if it is feasible practically and if it is available, then it is better to do the iron studies and then only give parental iron therapy. These are the indications to do the iron studies. What is the place of serum ferritin in pregnancy? If serum ferritin is less than 15 microgram per liter, it is diagnostic of iron deficiency anemia in pregnancy with a very high specificity, less than 15. But if it is less than 30 microgram per liter, it also indicates presence, possibility, strong possibility of iron deficiency, and it is an indication. That is why to start the treatment because of high sensitivity. Now, this ferritin level might be inaccurate as it arises with infection or inflammation. So, it is mainly indicated in non-responders to iron therapy in sickle cell trait or thalassemia, beta thalassemia minor before initiating iron therapy and before parental iron therapy if feasible. And this serum ferritin level is increased whenever there is increase in inflammation during pregnancy, such as in obesity, in preeclampsia, or any other infection during pregnancy also. It leads to rise in serum ferritin level. That is the drawback. Now, how do you suspect hemoglobinopathy on CBC? Now, whenever we do CBC, it is a very precious investigation and we need to be able to extract maximally from it. It is so easily available and it is comparatively an inexpensive investigation, but as clinician, we should know how to extract information from it. So what is done on CBC, how we suspect hemoglobinopathy is the best index which is used is called as Menzer index. Menzer index is MCV divided by RBC count. Whenever it is less than 13, this index, it is suggestive of beta thalassemia minor because in beta thalassemia minor, RBC production is normal. Denominator is normal and that is why the index or the ratio is less than 13. If it is greater than 13, it is suggestive of iron deficiency anemia as RBC production is less in iron deficiency anemia. Value of 13 is considered as uncertain and further investigations are necessary for confirmation of diagnosis. Presence of sickle cells on peripheral smear is suggestive of sickle cell disease. That is how CBC and PS together will give us an idea about hemoglobinopathies. What is the differential diagnosis of microcytic hyperchromic anemia picture on peripheral smear? Or other same answer will be what are the reasons for non-responders to iron therapy? Suppose you start iron therapy and patient is not responding, what are the other possibilities? Now, microcytic hypochromic anemia, hypochromic picture is present in 4 conditions. And out of this, if it is iron deficiency anemia, presence of poikilocytosis is there. That is the shape of the cells is variable. Anisocytosis is size of the shapes is variable, which is also present in iron deficiency anemia. And we can get pencil cells like this in iron deficiency anemia. And as we have already seen, Menzer index will be greater than 13. Anemia of chronic disease, there will be absence of pencil cells. And we have to search for any presence of chronic disease or chronic infection or inflammation in the patient. Beta thalassemia minor, Menzer index is less than 13. there are target cells which are present like this. Target cells are seen, and whenever we do the hemoglobin electrophoresis or we do the this liquid chromatography, high performance liquid chromatography, HbA2 level will be observed, which will, if it is between 4 to 8%, it is suggestive of thalassemia minor. Remember this figure also, HbA2. Sideroblastic anemia is diagnosed only on bone marrow examination, where what can be seen are the ring sideroblast. So these are the four conditions which forms a differential diagnosis of microcytic hypochromic typing on peripheral smear, and these are the three conditions: anemia of chronic disease, beta thalassemia minor, and sideroblastic anemia, where in spite of giving iron therapy, there will be no response observed in the patient. Now, why should we screen women for hemoglobinopathy in early pregnancy, especially in areas where the hemoglobinopathies are commonly observed? Now, pregnant women can have sickle cell trait or thalassemia minor. In that situation, we need to immediately see for the husband status. If both are having sickle cell trait or say thalassemia minor, we need to do the testing to know the status of the fetus. If fetus has thalassemia major or sickle cell disease, then next step is counseling of parents, and we have to discuss the choice for pregnancy termination or continuation, and as per our counseling and their decision, then we need to take a decision about the termination of pregnancy before 20 to 24 weeks. So it is a long process. First detection in the patient, then asking for the husband's status to be known, then going for the testing for the fetus and getting the report. So it takes at least 3 to 4 weeks for all this to be completed. And that is why my advice is, as a clinician also, we should be testing each case of anemia for hemoglobinopathy by doing either hemoglobin electrophoresis or better tests by doing a high performance liquid chromatography in areas wherever sickle cell disease or thalassemia major is commonly observed. It should be done at the first antenatal visit so that we get time to do all these things and discuss and do the proper counseling, and then accordingly, if required, do the termination of pregnancy as per the decision of the patient and their family members. Now, can an ideal diet provide adequate iron in pregnancy? If patient is very much aware and compliant and you advise her a diet rich in iron, can it be sufficient during pregnancy is the question. Or other way of asking is why we give prophylactic iron therapy. So why we give prophylactic iron therapy is there is increased iron requirement during pregnancy which cannot be met with a balanced diet also. So how much is the iron requirement? It is 6 to 7 milligram in second half of pregnancy and reaches as much as 10 milligram in last 4 to 6 weeks. Dietary iron absorption is around 10 to 20%. It is slightly increased. Absorption increases in pregnancy, but not more than 20%. And that much of the iron content in a balanced diet is not feasible. So that is why we need to give prophylactic iron therapy. Prophylactic, remember, if you are asked about prophylactic iron therapy, you should remember that patient is not anemic. Her hemoglobin is normal. Still, you are giving iron therapy during pregnancy, whereas therapeutic is whenever the patient has shown presence of anemia. Now, why iron requirement increases in pregnancy? There is increasing RBC mass. Fetal RBCs are forming. Fetus also needs more of iron. Placental development takes place, and all these lead to the total iron requirement in pregnancy, which is around 1000 grams. 1000, I'm sorry, it is around 1000 milligrams. Now, what is the first line treatment for iron deficiency in anemia in pregnancy? You have diagnosed it as iron deficiency anemia. First line treatment is usually oral iron therapy, and especially prophylactic iron therapy is to be given from second trimester. It is avoided in first trimester because it might increase morning sickness or it can worsen the hyperemesis gravidarum. Prophylactic dose is 60 milligram elemental iron and 400 microgram of folic acid by WHO, whereas government of India slightly increase recommendation of increased dose is there, 100 milligram elemental iron and 500 microgram of folic acid. Therapeutic dose is double of the prophylactic dose. Instead of giving 1 tablet per day, therapeutically we have to give 1 tablet twice a day or 2 tablets per day, 120 milligram per day or 200 milligram per day by Government of India of elemental iron. Now remember, we have to focus on elemental iron and not on the total molecule weight of the total molecule. So if it is ferrous sulfate, 200 milligram of ferrous sulfate tablet will be containing 60 milligram of elemental iron. This is an example. There are so many other preparations also available, and we need to be aware of how much is the elemental iron presence as per the molecule which is being used in the oral iron. Folic acid needs to be given along with iron. Folic acid, iron and protein, all three are required for hemoglobin formation. Folic acid deficiency in pregnancy is mainly observed because of the folic acid which is required for rapidly dividing fetal cells. Fetus needs more of folic acid, and there is increased urinary loss of folic acid during pregnancy. These are the two reasons why folic acid requirement increases during pregnancy, and if dietary supplementation fails to take care of it, there will be folic acid deficiency during pregnancy. How do we know that patient is responding to iron therapy or oral iron? There will be sense of well-being within a week with increase in reticulocyte count and increase in red cell distribution width in a week. How long will you continue oral iron therapy? It is once detected anemia, we need to continue treatment till the hemoglobin comes to normal level. Once it comes to normal level or it crosses the cutoff, then it goes beyond the cutoff, then it should be continued throughout pregnancy prophylactically once the desirable hemoglobin is achieved. It needs to be continued in postpartum period. Then at the end of postpartum periods, after 6 weeks after the delivery, we need to repeat hemoglobin. If it is normal, that is greater than 12 gram per dl, we need to continue the supplementation for another 3 months to take care of the stores. What are the various oral iron preparations you know of? Now, oral iron preparations, they differ as per content of elemental iron in it, as per their dissolution, whether they are getting dissolved in the intestine immediately or there is a late release, and according to the side effects. Side effects usually are as per the elemental iron content in the specific molecule. Examples are elemental iron in say ferrous sulfate is 30%, is 60 milligram. Ferrous gluconate it is 12%, it is lesser. So ferrous gluconate has less elemental iron, so the side effects will be less with the same dose. But the patient will be getting less of iron also because elemental iron content is less. Ferrous fumarate it is 33%. Now conventional tablets dissolve quickly, whereas modified release tablets or capsules they dissolve slowly. Mainly the iron is getting absorbed in the duodenum from the duodenal enterocytes, and it depends whether the tablet is dissolving quickly or there is a slow release of the iron. GI side effects is the main cause of non-tolerance and non-compliance to oral iron therapy. Gastrointestinal side effects are there, such as nausea is there, indigestion is there, constipation and or diarrhea can be there, and all these are so troublesome that leads to either non-tolerance or non-compliance to oral iron therapy. There are many studies which are available, which have been conducted over various types of newer oral iron formulations which are available in the market. Carbonyl iron, it has less GI disturbances than ferrous sulfate with increased efficacy. Ferrous fumarate is said to be more effective than carbonyl iron by some studies. Ferrous ascorbate, ferrous bisglycinate are more effective than ferrous sulfate. Slow release ferrous sulfate is better tolerated. So these are the conclusions of these studies. There is IPC, that is iron polymaltose complex. It has better tolerance than ferrous forms. All these ferrous forms, ferrous sulfate, gluconate, and all the other forms. Conclusion is there is no consensus for most effective and best tolerated oral iron, and whenever a patient has intolerance, we need to try and change the molecule to see which molecule the patient tolerates, which has least side effects and maximum efficacy for that patient. That is why for every patient the oral iron formulation, which will be best tolerated and which will have best efficacy, will differ from patient to patient. What other instructions you will give along with oral iron therapy are: patient has to take diet rich in iron, protein as well as vitamin C, and if available, iron fortified foods are to be consumed. She has to avoid tea, coffee, cocoa, or milk, all these containing tannin, along with the whenever iron tablets are being taken, or even along with the food also. Along with the meal, these are to be avoided. To take iron tablet before major meals or at least 1 hour later, 1 hour after the major meal. Not to take the iron tablet should not be taken anytime immediately after meals, and not to take iron and calcium tablets at the same time, as calcium also hampers the iron absorption. Now, why do we give universal iron supplementation in India? That is also a question which can be asked, or even for countries wherever it is given as universal iron supplementation during pregnancy. WHO recommendation is 30 to 60 milligram of elemental iron needs to be given prophylactically in pregnancy. Anemia is a severe health problem in a given country if it is present in more than 40% of the population in pregnancy. It is so in pregnant women in India, where some studies are showing as high as 80 to 90% of the women having anemia, whereas others are showing definitely greater than 50%. So in such a population, prophylactic dose which needs to be given is 60 milligram per day, and the dose increases to 120 milligram per day whenever needs to be given therapeutically. Prophylactic is 60 milligram, therapeutic is 120 milligram, but universal iron supplementation is recommended by WHO in India because of the high prevalence of iron, this anemia, iron deficiency anemia during pregnancy. How to give folic acid in pregnancy and why we need to give folic acid in pregnancy. Folic acid should be given peri-conceptionally. It should be started 3 months before conception and then it is continued throughout pregnancy. Reason is folic acid deficiency leads to neural tube defects, and neural tube development is completed by day 28 of fertilization. So day 28 of fertilization, by that time in most of the women, pregnancy might not be diagnosed. So we miss this opportunity of folic acid supplementation and prevention of neural tube defects if it is started after diagnosis of pregnancy. That is why it needs to be given periconceptionally. Prophylactic dose is 400 microgram per day, that is 0.4 milligram per day, and therapeutic dose. Therapeutic is whenever there is a history of previous baby having neural tube defect. Therapeutic dose is 4 milligram per day again in periconceptional period. Folic acid deficiency also leads to megaloblastic anemia during pregnancy. What are the features of megaloblastic anemia and treatment of megaloblastic anemia? Features are hypersegmented neutrophils, macrocytic erythrocytes, nucleated RBCs, and in severe disease we can have thrombocytopenia or leukopenia or both. So it will be a case of pancytopenia, and treatment is 5 to 15 milligram folic acid per day. With that, reticulocyte will increase and there will be even a correction of thrombocytopenia and leukopenia. Now, I have seen a patient coming with pancytopenia, severe anemia, severe thrombocytopenia, leukopenia, responding dramatically to intravenous B12 and folic acid administration. And we need to keep this in mind as a differential diagnosis whenever we get a patient of thrombocytopenia in pregnancy or pancytopenia in pregnancy as megaloblastic anemia as differential diagnosis, because it is one of the treatable cause of these serious problems, thrombocytopenia or pancytopenia complicating pregnancy. What is WHO recommendation for deworming in pregnancy? Single dose albendazole with a dose of 400 mg or mebendazole 500 mg is to be given as a single dose, one tablet, and it is to be given after first trimester of pregnancy. Which program is currently run by Government of India for prevention of anemia? It is called as Anemia Mukta Bharat, which was initiated in 2018. It has a 6x6x6 model. It is mainly focusing on 6 age groups with 6 interventions with 6 institutional interventions. So what are the recommendations in Anemia Mukta Bharat which are to be followed by obstetricians? First is for pregnant women, Anemia Mukta Bharat 60 milligram elemental iron with 500 microgram of folic acid is to be given. This tablet needs to be given one tablet per day prophylactically, or two tablets per day, one tablet twice a day to be given therapeutically. It is to be started from 4th month, and it is to be given throughout pregnancy, and minimum is for 180 days. Postpartum period, it needs to be continued for 180 days. That is another. That means for 6 months it needs to be continued as per the Indian scenario. Deworming is recommended in second and third trimester of pregnancy as a measure to again further reduce the anemia complicating pregnancy. And most important is for obstetricians, there is a strong recommendation by WHO as well as by Government of India for delayed cord clamping, DCC. So by Government of India, 3 minutes wait and then only you do the cord clamping unless baby is not crying and is asphyxiated. What are the main factors which decide the treatment modality in iron deficiency anemia in pregnancy? It is the gestational age, severity of iron deficiency anemia. As per grade, we have already seen there are 3 grades by WHO and 4 grades by ICMR, and whether patient can tolerate or is compliant for oral iron therapy. And then accordingly, we have the choices whether to give oral iron, parenteral iron in the intramuscular or intravenous form, or to give blood transfusion as packed red cell transfusion. Now, decision of treatment. As we have already seen, it depends on the grade and it depends on the stage of the pregnancy on this side and the grade here. So as you can see here, when the pregnancy is less than 34 weeks, oral iron is good for mild anemia. For moderate anemia, we can start with parenteral iron. Severe anemia, we can even, for severe anemia also, we can go for this second trimester parenteral iron can be tried. Whereas third trimester, it is better to go for PRC, blood transfusion, and very severe, less than 4 is definitely for PRC. So less than 4, irrespective of timing, blood transfusion, PRC, packed red cell transfusion is recommended. Whereas main difference will be here for 4 to 7 gram per diem. In that, depending on if it is impending failure, we go for PRC. Even if it is late pregnancy, we can try parenteral iron. And especially moderate anemia and pregnancies first, second trimester up to 34 weeks, parenteral iron can be given. For mild, we give oral. Postpartum mild oral iron. If it is moderate, oral iron or iron sucrose. And severe, we can try this FCM, ferrous carboxymaltose, which is an alternative which leads to the replacement for blood transfusion. So if it is not available, PRC needs to be given. Hemoglobinopathy, usually PRCs are effective. And if hemoglobinopathy in traits with iron deficiency is there, then we need to give oral or injectable iron, depending on the severity. So this is, I have myself prepared this in a nutshell, and you can be given various case scenarios in theory paper, or you can be asked in the form of case scenarios in practical examination also, and you need to give the answer accordingly, that even if it is severe anemia and early pregnancy, second trimester, we can try parenteral iron. Patient is compensated. If there is impending failure, then we need to go for blood transfusion. That is how you need to answer. This FCM is only to be discussed for postpartum, not for pregnancy cases. Antepartum use is not still proven as safe, and intrapartum uses, postpartum use is recommended. What are the indications for parenteral iron therapy is the most commonly asked question. Non-compliance, non-tolerance to oral iron. How you see whether patient is compliant? You ask the color of the stools. Black stool indicates compliance, and normal colored stools indicates non-compliance. So even if whether patient is giving history correctly or not can be cross-checked in this way. If it is a third trimester with moderate anemia, then parenteral iron therapy should be given. Postpartum moderate to severe anemia and compensated case, we can go for parenteral iron therapy. Contraindications to parenteral iron therapy, first trimester of pregnancy, as the safety has not been proven. If there is a history of anaphylaxis to it in the past, then it should not, it is contraindicated. Chronic liver disease, any active infection, either acute or chronic, is a contraindication. We need to remember these contraindications. Prerequisites are diagnosis should be confirmed, preferably by doing iron studies. There should not be any history of anaphylaxis to it. Facilities are to be available to treat anaphylaxis if it occurs, and oral iron should be stopped 24 hours before initiation of this parenteral therapy. So these are the various questions, or even if you are asked that what is your opinion about parenteral iron therapy, you need to tell the indications, contraindications, and prerequisite in the same yes, as include in the same answer without letting the examiner ask the sub questions. That is what I mean by a complete answer, that your answer should include indications, contraindications, and prerequisite. So many times we know, but we do not know how to express ourselves. So my request to all the students, you practice answering like this. Which parenteral iron preparation you prefer and why? Iron sucrose is the preferred parenteral iron preparation. It is given as 200 mg alternative with a maximum dose of 600 mg per week. Why it is the maximum dose is because it attaches to transferrin and there is complete saturation of this ion carrier, that is transferrin, and that is why there is no further, even if you give higher dose, it will be excreted, and that is why maximum dose per week is 600 mg. You need to be able to answer this also. It is associated with less anaphylactic reactions than iron dextran, but remember, any intravenous you are giving, rarely you might encounter a anaphylactic reaction, and that is why every intravenous drug, any intravenous drug, whenever you are giving it, administering it, it should never be given in an unsupervised environment. Close supervision is always necessary. We have intramuscular preparations, IV dextran, sorbitol, or iron polymaltose, but all these preparations are more painful, with leading to skin discoloration and possibility of anaphylaxis, especially more with intramuscular dextran, and that is why we have now shifted completely from intramuscular to intravenous because of the advantages of IV. Less painful, less anaphylactic reactions, and that is there is no skin discoloration, and that is why it is preferred over intramuscular. But wherever facilities for intravenous are not available, intramuscular iron should be given for moderate anemia and pregnancy is the Government of India recommendation, because there are many places, far off places in India, pockets in India, where still intravenous drug administration is not feasible or practically not available. So intramuscular iron is the best option for such places. Postpartum ferric carboxymaltose can be given. Single high dose up to 1000 mg can be given in 15 minutes is the advantage, but it is relatively expensive and not easily available, especially at government hospitals. How do we calculate dose of IV and sucrose? The formula all the students should they need to even memorize it and use it in practice also. 2.4 into hemoglobin deficit into patient's weight in kg, plus you add 1000 mg for stores. What are the indications for blood component therapy or blood transfusion or packed red cell transfusion in pregnancy? And commonly asked question is why you PRC and not whole blood? The reason is with the whole blood there is a possibility of having a heart failure in a severe anemia. So it is better to give PRCs. Hemoglobin less than 5 gram percent irrespective of period of gestation is the indication. Whenever it is 5 to 7 gram percent, then impending failure is there, features are there, then we need to give. If it is late in pregnancy, greater than 34 weeks, 5 to 7 gram percent, or patient comes directly in labor or immediate postpartum, we need to give PRCs in these scenarios also. Less than 6 gram percent with acute blood loss is a definite indication for blood transfusion, and if acute blood loss is associated with features of shock, then also we need to give blood transfusion. In hemoglobinopathies, the best way to treat the patient sickle cell disease especially is by giving blood transfusions. Why should we need anemia aggressively in pregnancy? Or in other words, the examiner is asking you, what are the complications of anemia? Maternal complications are intolerance to blood loss. Even with a normal blood loss in third stage of labor, patient might go in shock, and we have seen even mortalities with a very severe anemia. Patient will be intolerant to infection, and there will be increased risk of infections. So if infection is there, it will progress to sepsis, and the patient will go in septic shock faster with the presence of anemia. So it is said to be a silent killer. Anemia is said to be a silent killer. Any obstetric hemorrhage and patient is anemic, she won't be able to tolerate. Any puerperal infection, puerperal sepsis, we might face a severe morbidity or even mortality. Fetal and neonatal complications, there is increased prematurity, low birth weight, overall perinatal mortality increases, and long term, the newer evidence suggests that there is increase in autism, schizophrenia whenever the mother has untreated anemia. But maternal iron deficiency never leads to fetal or neonatal anemia. Baby is a perfect parasite as far as transplacental transfer of iron goes, but it leads to low iron stores in the newborn baby, so that the newborn baby is not anemic, but after say 6 months or 1 year, baby will start showing anemia because of the depleted iron stores. What are the factors affecting neonatal iron stores? Maternal iron deficiency, especially in third trimester, and timing of cord clamping. What is recommended timing of cord clamping by WHO? At least 1 minute after birth for all term and preterm babies who are not asphyxiated, should be at the tip of the tongue for all the students, whereas Government of India says we need to wait for 3 minutes for cord clamping under Anemia Mukta Bharat. So precious RBCs are transferring from the placenta to the baby, so that the male baby at birth only is gaining so many RBCs and so much of iron my baby is gaining, and possibility of having anemia. This intervention is taking care of prevention of anemia right from the birth. Now, what is hepcidin is commonly asked question related to the iron metabolism. Hepcidin is an hormone secreted by liver which regulates iron metabolism. It is an iron metabolism regulator. How? It inhibits iron transport by binding with ferroportin. What is this ferroportin? Ferroportin is an iron export channel to transport iron from enterocytes, mainly the duodenal cells. And even ferroportin is required for release of iron from macrophages and hepatocytes also. Hepcidin leads to decreased absorption or release via ferroportin by enterocytes, macrophages, and hepatocytes. So, if hepcidin level increases, there will be less of iron available, because it decrease in iron absorption will be there, as well as release of the iron from macrophages and hepatocytes will be lower. Hepcidin level increases in chronic inflammation, inhibiting iron transport, leading to iron deficiency anemia. In pregnancy, hepcidin level in a normal pregnancy is lower than in non-pregnant woman. Level decreases further in iron deficiency anemia complicating pregnancy. Hepcidin measurement can be used to diagnose iron deficiency anemia in pregnancy, and it is being used at present in the research scenario. It has a good sensitivity and specificity. Hepcidin level increases in preeclampsia, and that is how we get anemia and this preeclampsia. They go hand in hand, and how they go is with anemia. Preeclampsia level also possibility increases, and with preeclampsia, it further adds to the anemia by increase in the hepcidin level. With malaria, obesity also, there will be any infection, malaria or any other infection or obesity. All these are associated with increased inflammation, and it leads to rise in hepcidin level and it leads to the less availability of the iron, because it reduces the iron absorption and iron release. Now, what additional steps you will take in management of labor in a case of anemia? PRC to be given if hemoglobin is less than 7 gram per cent. Fluids are to be restricted to prevent congestive heart failure in a severe or very severe anemia. Especially whenever we are giving oxytocin, we need to be very careful. We need to increase oxytocin saturation rather than increasing the drip rate to increase the dose of oxytocin. Antibiotic prophylaxis needs to be given. Proper position oxygen administration if there is a patient who has severe anemia with impending, if there is a impending failure. Pain management has to be proper, and there should be active management of third stage of labor with prophylactic oxytocin administration, mainly to reduce the blood loss. Even normal blood loss in third stage, patient might not tolerate if she has severe anemia. Now, summary of investigations. Hemoglobin less than 11 gram per dl in third trimester or less than 10.5 in second trimester is an indication to do CBC and PS. PS shows hypochromic microcytic picture, and CBC is showing fall in MCV, MCH, MCHC with an increase in RDW. Then we can start the trial of oral iron therapy. Patient response is there, then we continue the same treatment. If there is no response, it is an indication to go for iron studies, or wherever facilities are available and wherever there is no problem, financial problem to do the further investigations, iron studies immediately after having a provisional diagnosis without going for a trial of oral iron. With iron studies, serum ferritin is done. It is less than 15, it is diagnostic. If it is greater than or equal to 15, it is an indication to further do the studies as total iron binding capacity and soluble transferrin receptor level. And we should also consider the in a non-responder. If there is it is a non-responder, other three possibilities, whether it is a patient has hemoglobinopathy by doing electrophoresis, or better investigation is HPLC, that is high performance liquid chromatography. And we need to see whether patient has any chronic disease, and rarely if all the other possibilities are ruled out, we need to go for bone marrow analysis to rule out sideroblastic anemia. Special comments about pregnancy are dimorphic anemia might be there, where CBC will be normal but peripheral smear will show microcytic and macrocytic cells in pregnancy. We need to remember that. And hemoglobin electrophoresis and HPLC need not be done in non-responders only. It can be done at first visit wherever the sickle cell disease or thalassemia is more commonly present or prevalent. So it needs to be done at first visit, and if it is sickle cell disease is there, then we need to treat the patient accordingly and do the assessment of the husband also. And if it is thalassemia minor or sickle cell trait, then we need to do the iron studies. Especially the reason is nutritional deficiencies are common and iron supplementation is necessary in thalassemia minor or sickle cell trait. To summarize the treatment, whenever there is a provisional diagnosis of iron deficiency anemia, we can start oral iron, especially for mild to moderate grade of anemia, and gestational age is less than 34 weeks. If there is good response, we continue with the oral iron therapy. Second trimester onwards, if it is moderate to severe anemia, we need to confirm the diagnosis by iron studies preferably, if available. And then we can give parenteral iron, as iron IV sucrose is the preferable parenteral form which is used, which is the most preferred form. Or we can, if not available, facility is not available, we can give intramuscular. And postpartum, we can think about FCM if patient can afford it or if it is available. Packed cell transfusions are indicated, or blood transfusion is indicated in uncompensated severe anemia and in very severe anemia, especially hemoglobin less than 4 or 5 gram %. With hemoglobinopathies, if it is sickle cell disease, blood transfusion is the main modality of treatment. For sickle cell trait and thalassemia minor, we should remember to do iron studies, and if it shows iron deficiency, we need to give iron. So we need to give the iron supplementation. These are the references: WHO guideline 2012 for iron folic acid supplementation in pregnancy, Williams Obstetrics 2019. This FOXY GCPR, that is good clinical practice recommendation, management of iron deficiency anemia 2017 is very good. Students can once go through it also directly. And Anemia Mukta Bharat by Government of India. Thank you so much.